Caring about the effects of long COVID on mind and body. It's a long presentation. There's a lot of information. Think of this as a reference you can come back to, but I thought it was important to really give the evidence that we have to date that it can inform our thinking going forward. So this is just a listing of my disclosures. None of them are in conflict with the topic of today's presentation. So research related to echo and work with diabetes with those companies mentioned there. I'm also the clinical lead for primary care integration with the Ontario College of Family Doctors and a consultant with the Canadian Partnership Against Cancer. I have to really thank Sanji for the information on mental health in these slides. And those of you who haven't followed Trisha Greenhall, she's a family doctor in England who's amazing on Twitter. You got to follow her. She has a lot of work and research happening on long COVID from a primary care perspective as well. And so this isn't supported by anybody but CAMH through the ministry's time as well. And wherever clear, I'll be giving you evidence-based information. There's nothing that's specifically evidence even informed. Most is really evidence-based, but where there's a gap, I'll let you know specifically. So our goal here is to distinguish between what we know about already, which is acute COVID, and think about long-term presentations of COVID now, and recognizing what those complications tend to be, and seeing that we can see what they're like and what approaches to care are the best practices at this point to approach long COVID. So what is COVID-19? We already know about the virus. That's the simplest part of the whole equation. That's the runny nose, coughing, fever, all the stuff that we were taught to learn about for the last 2 years. Small changes that we're seeing with Omicron now being more of an upper respiratory, throat and neck, and so kids are getting more croupy symptoms now, which is landing them in the hospital a bit more frequently for the acute cold symptoms. But the bigger question is what happens after that? What we know already very clearly is COVID-19 is not just a respiratory virus. So it will never be just the flu, which is a respiratory virus. What COVID is primarily a vascular endothelial disease. It's an angiopathic virus, which attacks your blood vessels, and all its complications arise secondarily to that. So even if, we can deal with the cold acute symptoms in the beginning, which is not the big deal part of the equation for the most part. For most people, it's what it does to your blood vessels that we care about more, short-term as well as long-term. And so what we see here is a depiction of what COVID tends to do. It attacks that lining of the blood vessels. And this is a picture, for example, of the lung and the inflammation that it causes. So in acute COVID, you have this lining getting very broken up and inflamed, water floods into the lungs, and that acute respiratory distress syndrome or drowning of the lungs, what was the worst case we saw with acute COVID. What we're also realizing is that endothelial lining is very much involved in things like blood pressure regulation, clot formation, immune activation. And so these are the effects we're seeing in both acute COVID in terms of the cytokine storm, but also the effects of long COVID. So what's in a name? So we have the name of COVID-19, and so there are many, many names we've had to this post-viral syndrome as we're trying to learn about it from the beginning. Long COVID is what most people have settled on in their vernacular, and that's what patients tend to also prefer the most. The official name just recently brought in October last year by the World Health Organization is post-COVID-19 condition. It's a very carefully chosen language. It probably will change over time. It's not a syndrome like other syndromes we've talked about in the past, like fibromyalgia, mainly because it has an identifiable cause, which is the COVID-19 virus, though the name may change. In gray, you see the long hauler COVID that drifted around for a while. That's the one we know is not as preferred by patients because it's a bit stigmatizing. Don't label patients by a disease. They're a person who has a condition, and the condition is the post-COVID-19 condition or long COVID. So what causes long COVID? This is the hypothesis that we have in literature so far. So we're thinking it has to do with that all those clots forming. So oxygen deprivation and hypoxic injury to tissue downstream from where COVID has caused inflammation. We know about it from the blood clots is where we think it's from as well, the thrombotic events. We think it's from bleeds, and there's more research now being published in the last couple of weeks about small hemorrhages that are happening, or even large hemorrhages sometimes after COVID because of damage to the blood vessel lining. And inflammation in particular, that's the immune dysregulation. We knew about that really early on with the acute COVID cytokine storms that we heard about, but now we'll learn even more, which I'll share today. So how is long COVID diagnosed? So we actually now have a clinical case definition from the World Health Organization. And what they're basically telling you is that post-COVID-19 is basically based on a probable or confirmed infection. Now that most people cannot get tested in most jurisdictions in the world, and definitely not in Ontario very well, you can't rely on waiting for PCR test. So we had to believe somewhere around like 4,000 patients officially by PCR in Ontario, estimated based on wastewater about 100, 120,000 yesterday. in Ontario. So there's a huge number of people who most will not ever get the PCR diagnosis. The rapid test is reliable when it's positive, but about 50% false negative when it's negative. So you can't really rely on that to know that you didn't have COVID and you're having symptoms. But if you have what you think is an exposure, a likely clinical history, and you're having symptoms that last at least 2 months and cannot be explained by alternative diagnosis, this may fall within what we call long COVID. And there's a long list of symptoms I'll go through that we think are symptoms of long COVID. We recognize that it ebbs and wanes over time as well. And there's gaps in this diagnosis. As I'll talk to you today, there's something we're realizing now are causally linked to COVID, but may not show up till much after 2 months. And so this definition also has some gaps to keep in mind. And we know the WHO is planning on changing the definition as we get more clarity. This definition applies to adults. And for children, there's proposals out there right now, but there's none that really have been as thorough as this one is so far. And keep in mind right now, what they're saying here is that this is a diagnosis of exclusion, that you haven't actually been able to find another cause. And the reason is that if we find something else we can treat, we should try to treat that rather than lumping it into long COVID, where we still don't have all the best treatments figured out. Now we're going to have problems going forward with this, and this definition will probably change because this is now a diagnosis of exclusion. There's just way too much COVID. We can't afford to do 1 million tests on everybody. And at some point, we're going to land on a positive diagnosis that this symptom correlation is most likely long COVID, rather than fishing for the less likely other causes. So there's actually an approach to managing long COVID that was designed by the NICE Institute in the UK, along with the College of Family Physicians there, as well as the Scottish group as well, talking about rapid guidelines in managing long COVID. And that was actually in 2020, so which is the basis of actually you saw the WHO's diagnosis. And what they recognize exactly was that we know that most people cannot be tested, so you can't wait for a positive test for sure to know if it's COVID. It's not just the severe illness patients who have acute COVID that you should worry about. It's not only the ones you can picture and do imaging for organs to see if there's damage, because we can't even do the imaging in most people. And it's not just symptoms alone. And so really what you need to tie it all together is that clinical history. And that's what's considered the appropriate way to give the label of long COVID at the moment. So how long does long COVID last? Acute COVID is about 2 or 3 weeks. It's a little bit shorter in some cases, but that's what it is. After the first month, you're really talking about that long COVID period. And they've got 2 different windows, up till 3 months and after 3 months. And this turns out to be a pretty good clinical boundary they've seen, because there seems to be a change that a lot of people may get better by 3 months, and the ones who don't are a different prognostic factor for their symptoms. So how many people does long COVID affect? You're seeing I'm asking a lot of questions in this, and hopefully we're hoping you have these questions in mind as we learn more, we put them to the box and understand long COVID better. So we actually have estimates from 2021, between 1/3 and up to 90% of people could have long COVID. That had to do with the diagnostic criteria changing, the symptoms we understood to be related changing. There's the ambiguity there. The Public Health Agency of Canada shows that, and they haven't changed their data on it till now, in the first month, that up to that 3-month period, 83% of people have COVID symptoms beyond that 3-week infection acute issue. After 3 months, nearly half still have symptoms. So a really large number. This may be slightly lower with some of the more recent data where we've been more specific and having better testing data, but that's still a high level to be concerned about. Children are also affected. So Italy early on did a very formal study where they tracked people after diagnosis, and they found that nearly half of adolescents who had COVID had symptoms up to 120 days. This is a very formal tracking questionnaire they did. Half of those kids who had long COVID had functionally impairing symptoms, particularly thinking and breathing. So it's a big challenge. That's what we send kids to do, is to learn and play and be active in school. And yet this impaired half of the kids who had long COVID, which is nearly again half of the kids who went there. The UK did a more, you come and tell us if you have a symptom, even if you're not sure you're COVID. So there was a public facing approach. They still found that younger children had about 13% long COVID and adolescents had about 15%. Most recently, there was a systematic review and meta-analyses that actually pegged the number. About 25% of children have long COVID. Now, the studies are quite different because the definitions change, but this tells us it's not infrequent at all, even for children to get long COVID, and it's not that far away from the adult numbers. It seems to be getting worse as you get older, and that's probably a truth that's emerging about long COVID. And so this is an adaptation of a graph we also on day 1 of the pandemic in Ontario designed to help us think about what we had to do. And the one thing they all missed and nobody thought about was long COVID. And I've given that wave of the curve because it does tend to get better over time, but it remains persistently high for a significant portion. And it's not just the line as a single point in time we worry about, it's a cumulative wave of all the people under the curve who continue on with symptoms. It's not just a case count today, it's a case count for every day for the last 2 years that we should keep in mind for something like COVID. Now, Ontario Science Table put a number out, estimating 10%. There really isn't any literature that really safely describes 10%. All the literature I'm seeing gives a consensus around 30% is probably a safe estimate of how frequently long COVID lasts. But even if you went with that estimate of long COVID of 10%, of September of last year, they thought that meant we were going to have 150,000 Canadians and 80,000 Ontarians who would have long COVID. This is before Omicron. And so I think we have to be ready for a much larger volume of people having issues with long COVID and how we manage that. So what are the symptoms of long COVID that people experience? So the words that the Wounded Healer study in the UK found that people describe the symptoms were primarily, I just can't function. I'm having brain fog, lung burn, trouble sleeping. And of course, we have correlates for this for the medical language and the way we evaluate it, but this is how patients describe it. This is the language you'll hear from them. This is a great graph that summarizes how symptoms change from the acute phase of COVID, which is the left blue bars, to the right red bars, which is long COVID symptoms. So you see some things become less frequent, like headaches and loss of appetite or muscle aches, and that gets better. But joint pains, for example, persist more significantly in the long COVID phase than the symptoms I just mentioned. Fatigue, chest pain, and joint pains are the big ones to watch for there. There's a small study that actually look at, are there difference in the kind of long COVID symptoms we tend to see depending on the variant? So with wild type original gangster COVID, you have loss of smell, difficulty swallowing, impaired hearing even. With alpha variant, they found there's more muscle aches and pains, more insomnia, brain fog, anxiety, and depression. And there may be even some more changes with Omicron. We know there's more upper respiratory symptoms, so maybe we'll see some changes there as well. Whoops. So the reality is there are at least 203 different symptoms of long COVID, and they're all listed by body systems here for you. And the graphs show you how they ebb and wane over time in general. So if you have a symptom, you can kind of see what is the trend of the symptom over time in long COVID, and you can reference that in detail in the study here. What we do know is that the symptoms tend to go down over time, obviously, which is really good to know, but still you have a pretty significant portion of people having symptoms even at 35 weeks of illness. If you had symptoms severity getting worse after 2 months, you're actually more likely to have more difficult long COVID that'll last longer. So that 2-month mark is a really useful threshold. If the number of symptoms you have even seem to increase at the 2-month mark still, you're more likely to be somebody who has more significant issues for COVID long term. So that 2-month mark tells you whether you're heading in the right direction or the wrong direction with the severity as well as the number of symptoms you're having. The big thing that WHO recognizes is functional impairment. So all the questions for the case form for WHO really focus on the disability. And just this last week, you had an amendment to the law in the US that actually talked about long COVID disability and how to apply for disability under it, really validate this is going to be something we do at a massive scale in societies. The Government of Canada's public health website also still quotes 10% of patients in long COVID are unable to return to work in the long run. Those are patients who have long COVID, not to patients who had COVID itself to begin with. So how are our organs affected in long COVID? This is where I can give you the research we now know reliably. This is a quick graph that actually looks at the different body systems. This is all mediated by damage and attachment through the ACE receptor that we're all aware of now. So different symptoms in different parts of the body listed there for you. So we'll go now what we see as the effects. So looking at the cardiovascular system, here there's a lot of studies, a lot of data. To summarize it quickly in reference, I've given you the number of patients and the population where the study was done up there in the top right. And we're often used to thinking about more severely sick patients are the ones who will have more long COVID. In general, that's true. Those are the patients, that's the data near the blue person in the hospital bed there for you as an icon. But the fact is we see a lot of long COVID in patients who actually were never hospitalized. And that's actually the red home symbol there to remind you, these patients were at home, they never went to the hospital. So in those who had mild disease, who were never hospitalized, they saw their risk over the next 12 months increase by nearly 40% of having heart failure, and nearly twice as likely to have a clot in their lung over the next 12 months. These are patients who were never in the hospital with their COVID. If you're hospitalized, you are way more likely, 6 times more likely to have a heart attack and 14 times more likely to have inflammation of your heart over the next year. We have now even data looking at 1 year later following those patients and seeing what happens. And these are patients, studies in the order of 150,000 patients, and now the next study, 1.5 million patients matched against 6 million controls. And these are only looking at patients now who survive the first 30 days. If you're sick enough, you die the first 30 days, we're not even looking at you. We're looking at the people who made it out of the hospital or made it past the first month of having bad COVID, as well as a lot of mild COVID in particular. And what they found was that the risk of heart attacks was 4 times higher than the baseline risk they would have had. And the risk of stroke was 6 times higher, even at 12 months after their COVID infection. And this is compared to their own baselines. If you were a healthy person compared to what a risk would have been if you were healthy. And because they stratified that the large number of patients against people who already had high blood pressure, age, diabetes, all those different factors, they could say specifically that these risks were due to COVID and not due to the other risk factors that person might have had. And that's a very significant risk to keep in mind here. So the one thing to keep in mind, back on that slide, the concern being the current definition of long COVID would not call that heart attack or stroke 11 months later long COVID. But now we have research really linking and saying, nope, it wouldn't have happened were it not for COVID. So even our case definition obviously needs to change over time. We know that scarring in the lungs is a big concern after having coronaviruses like these. We have a lot of data looking at the previous SARS-1 infection from 20 years ago, as well as its cousin, the Middle East respiratory virus, where they found nearly 10% of patients had scarring in their lungs after the initial COVID. Half of those still had it at 1 year, and a third of those still had it 15 years later. We know that scarring, pulmonary fibrosis in the lungs tends to be worse if you're older, especially over 80-year-olds. If you had more severe COVID illness, and that tends to correlate if you have diabetes, high blood pressure, that kind of stuff, or did you smoke? So they found that most patients had damage in their lungs on CT scan if they were discharged from hospital, but many seem to begin to improve after a year. This is now COVID-specific data we're talking about. But there still was a persistent number of patients still having scarring in their lungs at 3 months post. So scarring the lungs means you can't breathe through that space anymore because it's scarred down, and you have shortness of breath can be persistent after that. We also know now, just published 2 days ago from Sweden, 1 million patients age matched again with a lot of controls. We're looking at the risk of having deep venous thrombosis. We're used to those DVTs in your calves, by if you're flying for a long time or things like that. We now are seeing a lot more clots in your blood vessels as well as in your lungs after COVID. So what they found was that after having COVID-19 infection, the risk of having a clot in your blood vessels was elevated even at 2.5 months. And the clot in your lungs was elevated for nearly 3.5 months. And bleeding, so hemorrhages, were also still likely significantly more at 2 months. And in the patients who were really sick, you had a really 33 times higher risk of clot in your lungs, 5 times likely to have a DVT. Even in milder patients who never went to the hospital, their risk of a clot in their blood vessels was 3 times as likely, and a clot in their lungs was 7 times as likely for that duration. And that's a really big number to think about. We're seeing clots in the upper arms. We weren't seeing them as often from other causes. So these are higher risk scenarios that are emerging, we're seeing. The kidneys have a lot of ACE receptors. They're very much involved in blood pressure regulation. And so what we've seen is in people who only had mild disease or never hospitalized, their risk of having kidney disease was 15% elevated, and twice as likely to end up in their lifetime predicted to need dialysis compared to patients who never had COVID. Now, this is based on watching the trending on deterioration in their first month after having COVID, and then modeling thereafter based on what they had. ICU patients or hospitalization patients were significantly 13th more likely to need dialysis. We know there's now more and more of a link between COVID and diabetes. We knew people who were diabetic were more likely to get sick enough to be in the hospital, but in particular now we know that whoever was hospitalized was 15% more likely to need insulin before they left the hospital because of damage that was happening from the acute COVID infection. But now we have even a bit more concerning information because it's looking at all the rest of us who were probably not hospitalized. And this is a study of 8 million patients in the US where they found that, and they followed them for more than a year after they had their COVID. And what they found is having type 2 diabetes, the more common, what we call age onset diabetes, was significantly higher, nearly 40% higher than your own baseline risk of becoming diabetic in your lifetime within a year. So the risk is also happening in those who have the lowest risk of diabetes in general, higher for those who are not even overweight. So to put this in context, your individual risk of having diabetes may be quite low if you're young, healthy, don't have genetics. But whatever your baseline risk, you're now at a 40% elevated risk compared to that. So individually, the absolute risk may be small. Looking at a population, you're looking at a massive shift in risk of diabetes. Looking at the immune dysregulation in COVID, and this is the picture looking at all the different kinds of immune cells. You see what we call the innate immune system, which is what children are using a lot more of, which is the natural killer cells, the mast cells, the macrophages. These are things that indiscriminately go attacking, you don't need training. And then you have the B cell and the T cell, which are trained responsive parts, later parts of the immune system, which adults rely on more. What they found was that looking at the blood drawn from people at months after having COVID, there were significant distortions in the immune activation of cells many months later. And these were mainly mild disease, young age patients. And so what they found was you had natural killer cells, especially macrophages, being really elevated. I'll come back to that because macrophages are the ones that cause the most scarring in the lungs and things like that as well. So really distorted, elevated up to 6 months. Just published this week in Nature was an understanding of what happens and why this is happening. It's a really key study looking at the pathophysiology of COVID and long COVID. What they found was that you see the cells of macrophages, they go and chomp and munch on viruses and whatever they see around. They normally would eat the virus and digest it in these little stomach vacuoles they have. They found that COVID can escape those vacuoles and infect the macrophages themselves. So the immune cell now is infected and is a spreader of COVID potentially itself. The immune cells do not like being that. And what they do is when they recognize they're compromised, they actually do a suicide signal. And so what they do is they actually try to burn themselves in fire. Lots of hormones are released to destroy themselves. So before they spread the virus. But the problem with this immune activation, the storm begins there. Macrophages are big activators of that process. And that's what leads to the cascade we're seeing. And we're also seeing more scarring whenever the macrophages get activated. They draw more cells in to come attack where they're feeling overwhelmed by the invader. And so this is a key finding that the immune system, not through the ACE receptor now, but a different receptor, which is actually the base of the antibodies, is getting compromised by COVID as well. Autoimmune disease and COVID, this is the big concern. There's 2 ways that any viral infection, and COVID in particular we're seeing, can cause autoimmune disease following it. One way is if the molecule in the virus or the bacteria looks like something in your body and your body trains to fight the virus and then by accident learns to fight your body as well. That's molecular mimicry. The other way, which is much more common in COVID, we're seeing is bystander activation. So when one cell is infected and your body is attacking it, lots of inflammatory hormones are released to activate and fight the body. Problem is the immune cell next door that shouldn't have been activated also gets activated, and this one attacks your body instead. And so that's the process we see. We know that has to do with your genetics, and it also has to do with severity of illness. More severe illness, more immune cascades, more bystander activation, autoimmune disease. What we have clear evidence now of is that after acute and respiratory symptoms of COVID, people have new onset Guillain-Barré syndrome. That's that paralysis syndrome we saw after the flu sometimes. We have this more serious, fortunately rarer, but much more serious multi-system inflammatory syndrome that happens in children and adults about a month later. And that actually has unfortunately caused the death of some kids. We're also worried about a lot of new autoimmune diseases we haven't recognized yet because we're seeing antibodies to things we have never seen autoantibodies to before, to gut and liver and things, parts that we had never ever seen from other diseases previously. So we know that patients hospitalized for COVID are 4 times more likely to have antibodies that are like lupus antibodies or rheumatoid arthritis antibodies, all those different diseases that I mentioned there right now. I'll shift gears here now looking at thinking and the brain and how we function. So self-reported studies have looked at significant jumps in problems with memory, even 8 months after COVID. And these are patients who are even, for example, never hospitalized for COVID, are 3 times more likely to have memory deficits at 8 months. And this is looking at 13,000 patients in Norway. And those who were hospitalized, nearly 82% had neurologic problems. So a jump in the number of patients, even who are not hospitalized, significantly more if you're hospitalized. The UK does this ongoing study for many, many years, long before the pandemic came, where they do a lot of cognitive testing on thousands of UK residents year after year to just look at their cognitive functioning and try to associate it with other changes in their life over time. These are one of those mass studies that we rely on so much at our population level. And what they found, and they did very intensive, different kinds of cognitive testing to break down what's working, what's not working, and what deficits, face recognition, counting, planning, problem solving. And what they found was that the people who were hospitalized for COVID obviously had the worst decline. If you were in the hospital or you were in the ICU, you lost nearly a half standard deviation of your global cognitive score. That is twice as bad as the average stroke. That is worse than being born with a developmental disorder. Even if you were never hospitalized. Now, these are the patients in the red houses there. They found that you actually had cognitive decline as well, half as bad as the average stroke would cause. So significant declines in cognitive function, even if people were never hospitalized. This is a study published more recently in Canada, looking at nearly 2,000 patients of a young age, 37 years old, equal numbers of vaccinated versus unvaccinated patients in the study. And what they found was that actually it was a change in the executive functioning of people. So those of you who help patients with coaching, motivational interviewing, lifestyle changes, recognizing there was a significant response change in how well they could plan ahead for tasks after having had COVID versus those who didn't. And so it was obviously more severe the more sick you were with COVID, especially with your respiratory symptoms. It was still significant, even if you actually had mild or asymptomatic COVID. The UK, in that coming back to that study, they had pictures of people's brains. So we look at the functioning, but that could be multifactorial. That could be anxious or distressed, and could be pandemic stressors that could be confusing sometimes. Whereas this is now just looking at pictures of the brain and telling us what we see. And so they saw that everybody who had COVID, their brain shrunk. You lost gray matter. That was just a known factor across the base. In fact, what was worrisome was that they could not tell the difference between those who were hospitalized versus those who were not hospitalized because everybody's brains shrunk. Now, what we already know is that those who are hospitalized have more obvious functional impairments early on, whereas those who haven't would be a bit more spared and have more functional reserve. I'll be just a little bit longer story. We know mental health is a new onset of psychiatric conditions, nearly 18% more likely to have psychiatric illness after having COVID. And we know that the more, if you're hospitalized, the more severe it is. And we know for some reason that the people hospitalized are twice as likely to have severe, longer lasting delirium than we've seen for other causes for hospitalization in the past. PTSD after COVID is worse than actually being at 9/11. It's nearly as bad as having the SARS-1 or being in Katrina hurricane as well. So how do you plan treatment for long COVID? Well, the first thing is that primary care physicians, more like public health, is prevent it, because that's the best treatment that we have for it right now. So a quick reminder again that respirators are superior to surgical masks in preventing people from catching COVID and aerosol infections like SARS-CoV. So the N95 you're aware of, the KN95, which is the Chinese certified but not inspected version, which is sometimes reliable, sometimes not, depending where you get it. The KF94 is the Korean one, which has the wide flaps, which are very comfortable people to wear. These are both over the ear, and then surgical and cloth. If you cannot get the other masks, then layering a cloth mask with a surgical mask underneath, a cloth mask on top, gets you a bit closer based on the evidence to about 80%, which is better than the 60% you get surgical mask alone. All the guidelines will recommend hand washing, so we have not ruled out fomite transmission. We just know that aerosol is that much more common, and avoiding indoor gatherings is a big thing to continue with right now. Vaccination, we'd love to think vaccination fixes it all. Unfortunately, and it does help, but unfortunately, we have reliable data now saying that 2 doses only reduces your risk of long COVID by around 50%. And that's studies of 12 million patients and 1,500 healthcare workers. And we now have even more clear data looking at young patients, average age 50, 10% who had had 2 doses still had long COVID at 3 months. So the UK's rapid briefing found that there may be a small benefit to being vaccinated after having long COVID, but it's still a bit uncertain right now. So patients who are vaccine hesitant, they're still out there who have not had it, but who are concerned, who have phobias. CAMH is a great clinic you can refer them to make sure they get support. And how do you approach algorithms to care for long COVID? Making sure you look at all the biopsychosocial aspects, the community aspects in particular, because we know that it's not even which communities get COVID, and also have access to the resources to care for long COVID when it happens. A patient approach is really key, making sure everybody who has care gets it, that you're actually reducing burden. Continuity of care is a big part of things, making sure all of our different roles are involved, because this is going to affect so much of their life and their functioning, and involving them in research. There's a great summary here to work through if you have a patient in front of you with long COVID, about what to address. A focus on mental health, because you can make things better there at least while you're working through the comorbidities that you have access to, and what tests to order, what are futile, not really worthwhile right now. A recognition that there's also role for advocacy here, because there's care we can do and care that's missing. And supporting self-management for patients, and great guidelines there about making sure you're empowering them, letting them know they can share with their family. Resources, social media groups are key for patients, adults and children, and supporting families there. I'm putting all this in the links for you. If you are in Toronto, you can refer patients to the CAMH study that's looking to research what's happening with long COVID, what treatments would work, and that's the circle on the bottom right there for you. More programs are being setting up across Ontario as well as in BC through hospital programs, but they'll never be able to handle the volume that's out there. So a lot of us in primary care will be dealing with this. So let's work on it. And it affects healthcare workers, so make sure you're getting your support. There's a lot of misinformation, so stay open-minded and looking at what COVID can do. So I'll stop there.